Good morning, everyone. Thank you for joining us today. My name is Joan Batorf. I'm a professor in the School of Nursing and director of the Institute for Healthy Living and Chronic Disease Prevention here at UBC Okanagan. Before we begin today, I'd like to respectfully acknowledge that UBC Okanagan is situated on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. I also want to acknowledge that many of you might be joining us from other places, both near and far, and I want to take a moment to acknowledge the traditional owners and caretakers of those lands as well. We're delighted to be offering you another webinar this morning, and just a few housekeeping things before we begin. You may notice a closed captioning box on your screen. It can be moved to any place on your screen just by clicking and dragging it. Or if you prefer, you can turn it off with the closed captioning live transcript button on the menu bar. So today's event that we are delighted to bring to you is a webinar that's co-hosted by the Institute for Healthy Living and Chronic Disease Prevention and our partners, the North Okanagan Hospice Society. And today I'm delighted to introduce Lisa Matthews, who's the Executive Director of the North Okanagan Hospice Society, who's going to introduce our speakers. I'll turn it over to you, Lisa.
Oh, you're muted, Lisa.
I am muted. Good morning, everyone. And thank you, Joan. My name is Lisa Matthews, and I'm the Executive Director of the North Okanagan Hospice Society, and I've been in this role for 9 months. North Okanagan Hospice is a residential, 12-bedded residential hospice that provides services to the community of the North Okanagan. We have 12 beds here, and not only do we provide residential services, but we provide grief and bereavement counseling services and a number of community programs. And we're delighted to be able to take part in this webinar today. I'd like to introduce our facilitators, Elizabeth Beddard-Huber from the BC Centre of Palliative Care, and Nicole Wikjord, clinical nurse specialist for the First Nations Health Authority. Both of these facilitators have decades of experience in palliative hospice care and are certified hospice palliative care nurses. And I would like to introduce our topic for today, which is adapting the serious illness conversation guide for patients from diverse communities. And I will hand it on over to Elizabeth and Nicole. Thank you.
Good morning, everyone. It is a great pleasure to be here. You can see our topic slide there, which tells you what we're here for and what you signed up for. So we're really thrilled to be able to discuss this with you today. Excuse me. So I am Nicole Wikjord, as Lisa said. So I am a white settler of mixed European ancestry, mainly Norwegian, Hungarian, German. And I am calling in today from Coast Salish territory, specifically the Kakite and Coquitlam nations. And I'll turn it over to Elizabeth.
Thank you, Nicole. I'm Elizabeth Beddard-Huber, and I am the clinical lead for the Serious Illness Conversation Initiative with the BC Centre for Palliative Care. And on behalf of the Centre, I would like to acknowledge that the land on which we work is the unceded shared traditional territories of the Coast Salish people, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And today I'm speaking to you from the Sunshine Coast, the unceded shared traditional territory of the Squamish people. Thanks.
I just want to recognize a couple of colleagues that aren't with us here today. So Kathleen Yu is worked with Elizabeth and my colleague Gina Gaspard, who was the predecessor at First Nations Health Authority in developing and modifying the tool, which we're going to talk about. So neither Kathleen or Gina could be with us today. So our objectives today is really to describe the rationale and process for adapting the clinical tool, which is called the Serious Illness Conversation Guide, for cultural appropriateness for patients from diverse communities, but we're focusing on the adaptation with First Nations people. So just a quick history of the Serious Illness Conversation Guide. It is actually a tool that is used for people who have serious illness and are at risk of dying. So this photo here is a picture of Dr. Atul Gawande, and he's very well known for the checklist manifesto. So he is actually a surgeon and helped to standardize using checklists in the OR. But what he noticed was he really struggled with conversations that he needed to have with patients and their families about what was happening with their illness and what was ahead with their illness trajectory. And so he went to one of his colleagues, that's Dr. Susan Black. I should have said Dr. Gawande was at Harvard Medical School, and as well as being a surgeon there. Dr. Susan Black is a palliative care physician there, and he approached her and said, is there any way we could develop something like the surgical checklist that would make the conversations I have with patients and families appropriate to make sure we're hitting all of the right elements, so to speak? And so the Serious Illness Conversation Guide was developed and tested on patients around Boston. What I will say was that was the tool that is called the Serious Illness Conversation Guide. So in nursing and healthcare, physicians use the tool. It is a tool to use with anyone that is at risk for dying. So just switching gears a little bit to talk about First Nations culture. So I just want to give some definitions to give some context to remind us about what cultural safety is. So it's essentially when the client or the person, I'm going to say the person receiving care, feels safe. So for some people, there is a real struggle, for many people actually, around the power imbalances that are inherent in the healthcare system, as well as inherent in the fact that their physician has years of medical education. So what we're really wanting with cultural safety is where the person feels safe receiving healthcare. And it's important to know that I, as a nurse, can't say that I'm doing cultural safety, because it's not up to me as the nurse to say that. It's that the patient says our interaction felt safe together. So conversely, cultural humility is about, for me as a nurse or you as healthcare providers, to have this ongoing internal process within ourselves about reflecting about our own personal biases. There are many biases. So it could be, gender biases, it could be cultural biases, but really, and systemic biases are large as well. But what we're really wanting to do is maintain this ongoing respectful process and acknowledging oneself as learners. So certainly for myself, I started with FNHA in 2020, and I'm still learning more and more about cultural safety in my journey with cultural humility. Our next slide here talks about the cultural iceberg. So I think when we think about culture, sometimes it's easy to think about what we see on the surface or the outside things. So this is things we see for people, such as how they style their hair, what kind of clothing they might wear. It could be a religious symbol that they wear, which we say, oh, they identify as a certain culture. Or we start to make our assumptions or isms start to come through, perhaps. Where the deep culture are the things that are really important when we're talking with someone about advanced care planning and serious illness. So these are the things that we found were important for First Nations people. For example, who should be present when decisions are going to be made about healthcare, or who should be present when the serious illness conversation is going to happen. It might be, we found that for some First Nations communities and families, that the time of day that the conversations happened are really important. There are also cultural attitudes around whether pregnant women can be present. And then another big thing with decision-making is how those decisions are made. It may, the culture may not value autonomy in the same way that Western culture does. It might be that decision-making is shared. I am going to turn it over to Elizabeth now to talk about the Serious Illness Conversation Guide.
Thanks, Nicole. Share our story about how we introduced the Serious Illness Conversation Guide to the nurses working in First Nations communities in British Columbia. And the guide is up on the screen right now. And you can see that on the left-hand side, there is a conversation flow. And this, it basically goes through 5 steps of the conversation. And it is the setting up of the conversation, asking permission to have the conversation, assessing the understanding that the patient has of their prognosis, and then sharing a prognosis with the patient with regards to their preferences of what they want to know. Then exploring key topics, and those key topics would be the goals, the fears, the strengths of the patient, and critical abilities. And what we mean by critical abilities, what is so important to the patient that they couldn't see themselves living without that, i.e. personal care. And then looking at trade-offs, what is the patient willing to go through? Are they willing to go out of their community to a hospital for a length of time to buy more time if they needed extra treatment? And then closing the conversation, we would look at summarizing what we heard. It is a listening conversation. And then taking that and making recommendations based on what we heard from the patient. On the right-hand side of the guide is patient-tested language. And as Nicole mentioned, most of this was tested within an urban setting with mainly a white population. But Ariadne Labs did test it with African Americans as well. And the strength question was embedded into the guide at that point. So I'll ask Nicole just to move the slide forward. And what we did is we brought this to the nurses at the Nursing Education Forum back in 2017. And we explained that the intent and the purpose of the guide is to prepare clinicians to really explore the patient's values, their goals, and their preferences, to share the prognosis, as I mentioned, according to what they're willing to hear, what they are prepared to hear, to strengthen relationships, not only with the clinician and the patient, but also with their family, enhance patient control, and in general, improve the patient's experience when facing a serious illness. And so Nicole sort of spoke about when we would use this type of conversation, and it is used with patients who identify as having a life-limiting experience, illness, and that they could be less than a year for them to live. So we use the surprise question. Would you be surprised if this particular patient died within the next year? And if your answer is no, I would not be surprised, then they would probably benefit from a serious illness conversation. So this is what we presented. So we'll go to the next slide, please, Nicole. And what we heard from the nurses is that they felt that the guide did not have an Indigenous lens, and therefore it was not culturally safe. When we look to how First Nations people see health, they see it from the perspective of being very inclusive of the physical, the spiritual, emotional, and mental states. And you can see the wellness wheel here on the slide. Next slide, please. So we asked ourselves, well, what are the concerns? What are the issues? And we needed to identify it. And we also needed to clarify with the nurses what their concerns were. So we did a series of online surveys, and in 2018, we had the nurses join us for focus groups or sharing circles to delve a little bit deeper into what was happening or what they felt was not safe within the guide. We also reached out to colleagues who have tested the guide within non-white populations, and in particular, Lee Manson from New Zealand. We reached out to them. They had tested the guide with their patient populations from European backgrounds, but also with from Maori backgrounds. And what Lee was telling us is that a really good method to gather feedback was the co-design method, because it was effective in mitigating power differences when gathering feedback from various groups. So next slide, please. So what we did is we took the feedback we heard from the nurses, we took the feedback we heard from our New Zealand colleagues, and we adapted the guide and presented it to two First Nations communities. And we asked the elders and community members to give us feedback on what they thought of the guide. So first of all, what we did is we demonstrated how it would be used in clinical practice. And then we divided into smaller groups, and we asked them each to rate the question as whether they thought it was appropriate to be used. We're happy with it. Then they would color code it green. The next thing would be if it needed some work, they could color code it orange. If they thought it was totally inappropriate, then we would say it was red. And at the end of that, we asked them, is there any other question that we should be asking that we didn't ask? And then next slide, please. So what we learned is that they really wanted us to be direct. And just for an example, one of the first question we proposed to them was the setup question. I'd like to talk about what is happening with your health and do some thinking in advance about what is important to you so that I can make sure we provide you with the care you want. Is this okay? Their feedback to us was that that was too wordy. And they suggested, how are you feeling? Can we talk about your future health? Is this okay? So a big difference there. But so that was just an example of some of the feedback that we got. Also, the inclusion of family was really stressed, and it made us aware that, as Nicole was mentioning earlier, that in preparing to have the conversation, we almost have to have a pre-conversation to find out, as Nicole mentioned, who should be present, where we should be holding this conversation, and what time of day. This is also very important. And then asking permission, not just at the beginning of the conversation, but throughout the conversation, because at some point, maybe we need to stop and rethink this. And then the other thing that we found fascinating was the Maori people really like the inclusiveness when they're having a conversation, and they use the word we a lot in their questions or their discussions. Whereas the First Nations elders and community members said, no, it's not the clinician's illness, it's the client's illness. So, and also, of course, allow time for that storytelling. Very, very important. The nurses had suggested that we use or embed the dignity question. What do I need to know about you to give you the best care possible? And the elders and community members that we talked to said, yes, that's a good question to include. And then next slide. So here is the version, the adapted version we worked on with the First Nations Health Authority. And you can see on the left-hand side, there is a tool to prepare for the conversation. And we've stressed how important that is. And also to, you know, if the client or the patient is asking, what are we going to talk about? Preparing them to think about what's important to them, what they want to know about their prognosis, just giving them hints about what to think about prior to the conversation. And then on the right-hand side is the adapted version of our the tool that we created. And then the next slide. So we took this for full circle. We had presented it in 2017, and then in 2019, we went back to the Nursing Education Forum. Obviously, this was pre-COVID, so we were actually in person. And we were really happy with the response from the nurses. They were very satisfied with the work that we had done. And one nurse, as you can see, and I recall feeling it was really not through an Indigenous lens. I can only say kudos for the updated version and no new suggestions this NEF, Nursing Education Forum. So we were quite pleased with the response that we did get from the nurses when we represented it. And the next slide. However, when we're, sorry, Nicole, just you could go forward. I'm afraid I think, unfortunately, my computer died. So hopefully Nicole is moving the slides, but
Elizabeth, I'm
thanks,
just on
Nicole.
this. Yeah, I'm just on the slide. Adapting tools to enhance cultural sensitivity can have unintended consequences with the concrete showing.
Okay, thank you. And I've come back in, so I guess I've been having problems with my internet, so I do apologize. But just reflecting on any kind of adaptation to a tool, there is a cautionary message that we really should be thinking about. And this message came from Dr. Justin Sanders from Ariadne Labs. He said, you know, we bring multiple cultural lenses to our lived experience of the world and illness. Adaptation may try to capitalize on one of these lenses, but it could leave others unacknowledged or implicitly embedded in ways that we do not understand. In other words, one size does not necessarily fit all. And it's interesting to note that Ariadne Labs, the developers of the Serious Illness Conversation Guide, are also working to gain insights into strategies that drive equitable improvements in serious illness conversations and care. And they have adapted the co-design method in their explorations as well, where they're asking clinicians to rate the questions as green and then give feedback and suggestions if they rate them as orange or red. And then the next slide. So with this in mind, we had to ask ourselves another question. Is this adapted serious illness conversation guide culturally and linguistically acceptable for all English-speaking populations in British Columbia, irrespective of ethnicity and socioeconomic status? So to answer that question, we sent out surveys to clinicians who had been trained in how to use the Serious Illness Conversation Guide and asked them to use the adapted version and give us feedback. And we also arranged focus groups with members of the public from different ethnicities. And next, please, Nicole. So the clinician surveys were set up to ask clinicians to rate each question as either green, orange, or red, and provide suggestions, just as we did in the groups with First Nations, for those who had been rated orange or red. And this was the same approach we took with the focus groups. And then we took all the various responses and looked at them and then made a decision as to whether or not we should make any further changes to the guide. So the next slide, please. The virtual focus groups were small. We didn't have a huge turnout. We feel that a lot of this was due to the fact that we were doing these focus groups virtually, and also due to the fact that COVID, it was in 2020 in the spring, and I think everybody was very overwhelmed with COVID at that time. But you can see here, we did manage to hold 5 focus groups, and 3 of those were from non-European descent, Chinese, South Asian, and Indigenous. And then the next slide. We took all, as I mentioned, we took all the responses from the clinician surveys and also from the focus groups. And we set a very high bar for consideration to make any further changes to the adaptive guide. And the reason was that the bar was so high was due to the fact that we had a low response rate on the surveys and also in participation in the focus groups, which resulted in very limited data. And so due to that fact, we didn't feel we could do further changes. And also we knew that the language had been extensively tested prior to us doing this recent survey and recent focus groups. So we didn't feel we needed to do further changes. And you can see here that we do recommend or identify areas of concern that kind of came up from what we had studied. And so if there were an emerging national initiative to further evaluate the adapted serious illness conversation guides, we would highlight these 2 areas for special attention. One of the areas is sharing prognosis, and in the guide, there's a use of this wish, worry, wonder framework, as in the time-based sharing of prognosis. I wish things were different, but I worry that time could be as short as weeks to months. And the feedback we got was they didn't like the word worry. They would prefer us to say concern. We've heard that from others. So it's kind of up for debate. And the other area that kind of was highlighted was in the exploring key topics, that we needed to explain a little bit further what we meant by certain questions. The dignity question that I shared with you earlier, what do I need to know about you to give you the best care possible? Should we identify what we mean by what do we need to know? For example, do you take Chinese medicines or alternative medicines? And then further explanations about what we mean by what abilities are so important for you that you can't imagine living without them. Ability being maybe having the ability to do your personal care, or cognitive ability. So these are some of the areas that we highlighted. And then next slide. So our work that we did from 2017 to 2019 is written up in the International Journal for Indigenous Health. And that is available in open access. And I believe Joan has shared that link with you. And it describes the promising practice. And a promising practice is described as an intervention or activity that has an impact on health status demonstrated through research, evaluation, and/or systematic review. And I think Nicole showed you some of the other tools that are available. The Serious Illness Conversation was and is part of the Creative Commons license, which means that we could adapt it with permission from Ariadne Labs. And the original is also available through Ariadne Labs. And then the last slide is I would just like to thank you and to let you know that this information, the guide, the adapted guide, and the article are available on our center's website as well. And that is basically what I have to say. So thank you very much for your attention. And I think we'd open it up for questions.
Yes, thank you very much. That's really great work. I noticed that there was a question that you answered, Nicole, but it just came to us, so I'm just going to repeat it. Winter asked if the serious illness conversation should be led by nurses, physicians, or others, and who should do it. And I guess, and you responded, anyone can do it. So my follow-up question to that is there someone who's best positioned to do it and who's perhaps had the most success from your observations in using this critical illness conversation guide?
It's a great question, and I think it was Winter that asked it in the chat.
Yeah.
I think the big thing is that the best person to have the conversation is someone who's got relationship with the person. And so I think probably, the original physician that we talked about struggled as a surgeon because he didn't necessarily know the people he was needing to have these conversations with. So it is best if people have relationship. I know nurses sometimes feel they might not be comfortable talking about prognosis, but part of the education and training when people are learning about the tool is to recognize that we're not very good at prognosis, and we can talk about prognosis in terms of function rather than just time. And Elizabeth, I wonder if you want to comment on the social workers who take the training.
Exactly. And a lot of what we've been doing through UBC is interprofessional training, and occupational therapists and social workers have been really keen because they see their role as being very supportive of the serious illness conversation. OTs, especially through sharing prognosis through the functionality area, I wish you would feel this strong going forward, but I worry that you will be declining. Uncertainty is an area that have really come forward and said, this is really helps me in my practice, is, just talking about a prognosis is not being certain. We don't know what's going to happen in the future, but things could change very, very quickly. So definitely both social workers and occupational therapists have stepped forward. We just did a study, a pilot at the BC Cancer, and we wanted to interview clinicians as well to find out what they felt with regards to their role. And we interviewed dietitians and pharmacists, and they just felt that they could play a huge part in having this serious illness conversation. So what it really talks to is that if it's a team approach, it's even better. It just depends where the person is and who's involved, but definitely looking at an interdisciplinary approach to having these types of conversations.
That's great. And I see Vicki also mentions, would this be something a chaplain would be able to talk about as well? It sounds like it would be.
I think
Absolutely.
so. Yeah, so I think what I just wanted to add on to that, because I saw the question about the chaplain too, is like the serious illness conversation guide is meant to be a tool, right? So when we teach it, people can sit down and go through the whole tool, and it's very thorough. It can take anywhere from, 15 to 25 minutes, depending on what the answers are and how things are going. But we know that this is a tool for advanced care planning, and those are ongoing discussions. So it might be that a chaplain has some of the discussion with the client or the person, and nurses are on reviewing that. And then as the person's condition is changing again, they may have different answers to their questions. So this is really meant to be, it's a team event, so to speak.
Right. It's not a one-off.
That's right.
Absolutely. And I think that I just want to reiterate what Nicole said. It is a process. And so it's not a one conversation, but it's an ongoing conversation. And the other thing that came up in a lot of our training is with nurses, they say, sometimes I use part of the guide. I don't sit down and have the whole conversation, but during the process of care, I use maybe one or two of the questions just because the wording, I feel confident with the wording, and then I can delve a little bit deeper and then share with my team that maybe more conversations should be held.
Great. Lisa, do you want to pick up the next question here from Marilyn?
Sure, I can. So this is a question from Marilyn. From the limited feedback you were able to receive in 2020, were you able to formulate any conclusions about the suitability of the adapted tool for all cultures and ethnicities? And I was curious about that as well. So thanks, Marilyn.
We didn't do any further adaptations, but we felt that it was a suitable guide. But I know that there's been quite a bit of work done through Vancouver Coastal and the Chinese community, and they used very similar process that we did to see if it was suitable for that particular population as well. But the general consensus from what we did learn in 2020 when we did this work is that, yes, those questions that you have put forward are important, and that we do have to have a listening conversation with our patients.
I actually have a question. Thanks for that, Elizabeth. I actually have a question to add on to that. When we're working with lots of our immigrant cultures that have just come to Canada and they have English as a second language, what are the challenges that you feel that this tool may have with those clients and trying to get that message across?
So Vancouver Coastal did a big program, and they've actually translated the guide into, I think there's nine various translations, and that is available through our website at the center and also through Vancouver Coastal. And what the team did is they really tried to understand what we were getting at with the questions. And sometimes when you translate it the meaning changes. So they were very, very particular. They also have an online course for translators to actually go on and have a better understanding of the meaning of what the questions are meant to ask. And so, yes, this area is a big area. When we're dealing with people from, that English isn't their first language, because meaning is very important.
Thanks.
And the other thing that came up over and over again is not to have family be the translators, but to bring in a professional translator.
Mm-hmm. That's great. I'd encourage people who are joining us to add any questions they have into the chat. And while we're waiting for any additional questions, I do have another question, and I'm wondering about the training. So how long does the training take? How would any of these professions that we talked about working with clients access that training? Can people do it on their own? So I'm just wondering more about the training and what it involves.
Okay, thanks, Nicole. I think that we have done a lot of training throughout the province. So in each area of British Columbia, there are trained facilitators or master trainers. Mm-hmm. The training for a clinician to have the ability to use the guide is about 3 hours. And it basically is about an hour and a half of didactic, just kind of the background of the importance of the guide, what the research tells us about having these types of conversations, what the concept is. And that can be done online. There is an online module that we did prepare, and it's through the Learning Hub. So that can be done, but it needs to be attached to role play. Role play is what makes the training so important. Interdisciplinary role play makes it even better and richer. It takes about an hour and a half. There you play the role of the clinician and a patient, and then there's also an observer. So the role play of the clinician would be asking the questions according to the guide. There's a script for the patient to follow so that they're not a nightmare patient, so to speak. And then you get the kind of flow of the conversation. So it's about a 3-hour session. That can, there's lots of, like I say, in each health authority and like at the BC Cancer and at the BC Renal, there are many trained clinicians to facilitate those types of workshops. And just to let you know that down the road, we're piloting clinician workshops through Palliative. So eventually it will all be available through Palliative. And then I think it'll be easier because it's the role play and setting up the facilitation that is the most complicated. Also at UBCO, I know Vicki Kennedy and Shannon have done quite a bit of work in doing some training and clinician workshops with the nursing students. UBC Nursing in Vancouver, they are going to be embedding the clinician workshop into their core curriculum. Medicine has it in their 4th year as part of their transition into professional practice. The international medical graduates who come back to Canada and do, I think it's a 6-week orientation, and then they go into their residencies. They have that as part of their core curriculum as well. So it's slowly being embedded into undergrad work, which we're absolutely thrilled about. Because it's not just the palliative clinicians that should be doing these or having these conversations, it's all of us. So we're trying to reach out.
That's fabulous. Really great. Lisa, I'll let you pick up the next comment.
So this comment is from Diana Moore. Hi, Diana. I do know Diana. Trusting relationships is the utmost in all we can do, and communication is also inclusive in relationship building. Do we have translators, interpreters for our Indigenous community members? Have our Aboriginal patient navigators, liaison people been included in the surveys, and did the surveys and the development of the guide include our Indigenous community members in urban areas?
Mm-hmm. So it's Nicole. I'll tackle the question about interpreters. So as far as I know, there are no interpreters that are speaking Indigenous languages as part of provincial health, because we have a provincial interpreter. I'm forgetting what it's called right now, but it's in provincial interpreter services. And so there are over 35 different dialects within BC. So I actually don't know. I don't think there are. So, but wherever possible, we try to not use the family member at the bedside who's with the person to do translation. So this is still a gap in practice, certainly, and a gap in the healthcare system. As far as the navigators or liaisons being included in the surveys, I don't think they were included because they are usually employees of the regional health authorities. And when the surveys were done, it went to the nurses that work for First Nations Health or who work in the communities that are working for their own nation. Elizabeth, can you add on anything to that?
With regards to interpreters in the Indigenous areas, I'm not sure.
No, I meant
I think,
whether the navigators were part of the surveys that went out to the
oh, I'm sorry. No,
Yeah.
no, they weren't. It was the nurses. So nurses who actually had signed up at the Nursing Education Forum. Sorry, Nicole.
Mm-hmm.
And then the last part of the question was whether the surveys included Indigenous community members in urban areas. So one of the communities is very close to the Nanaimo. So I think you would call that semi-urban. I think Nanaimo's urban. But we didn't target, there was no targeting of friendship centers. So in First Nations Health, we call people who are living in urban areas, urban in a way. So their home might be Ontario or Saskatchewan, and now they're settled in Surrey or Burnaby or Vancouver or Kelowna, and those are urban in a way. And we didn't do that as part of the survey.
That's great. I'm wondering what you think the next steps are in this development of this tool, if there's any further development that you think needs to happen. You know, do we need, I guess I'm wondering if we need additional research around the use of this tool, or what you think about that.
Absolutely. I think what we need to do, we've done a lot of work getting data back from the workshops and the training that we've given. But what we need is to reach out to patients across the province from all backgrounds and find out if it's what the outcomes are. Is it beneficial to them? And then also we need to reach out to family. So we have looked at the, what's been done. There hasn't been a lot on patient outcomes, and there hasn't been a lot on family outcomes. So this is a gap. And so definitely need to go forward with that. And also we were looking at what stands in the way of having these serious illness conversation. What are the barriers and what are the enablers? And so this was the pilot that we were working on with the BC Cancer is, and time is oftentimes what people will say. Other people will say they're not prepared, they don't have the confidence. So how do we build that confidence? Fraser Health is looking at, we do the education, but then it falls flat. We need to really look at who's supporting this from the system point of view. Where are we going to document? How are we going to access this information? So there's lots of room for research and moving forward. I absolutely think there is. The center has been working on putting a quality improvement strategy together and looking at what's been done in regards to collecting data on patient outcomes, family outcomes, system outcomes. But it hasn't been done. It needs work.
I think we have some students who've joined us, so it looks like there's lots of topics for thesis research there that you've just outlined.
Totally.
And I know you'd welcome them to do
absolutely
research with you.
And we just had a master's student working with us on it too, just trying to develop a patient interview guide that was sensitive. Yeah.
Yeah, that's great. That's great. I see there's some follow-up comments to your conversation, Nicole. Do you want to share those with everyone? Oh, you're on mute.
Yeah, sorry, there was a question from Diana about which communities, because she says that there's a large urban in a way population in the communities that she serves. Elizabeth, because I wasn't around when the testing was done in the communities, I know one was Nanaimo, but I don't know the other one. But I think we do need to explore this further with other populations.
Mm-hmm.
Which other?
Absolutely. The other one is just outside of Victoria.
Great.
So they were closer to urban than northern. Yeah. Definitely room for more. We did feel we reached saturation. That was the general consensus with our team because there weren't any further changes that we were getting from our focus groups. Mm-hmm. So that's why we didn't do more. Yeah. But there's no reason why we couldn't.
Yeah, absolutely. Absolutely. Well, Lisa, I'm wondering if you have any other questions or comments that you want to share.
No, I just want to thank the facilitators that came on and yourself, Joan, and allowing us to join in this webinar and our community here in the North Okanagan, which I think there's a fair few of our people from this area to come on. So I'm really delighted to be part of this.
Yeah, well, thank you. And I do also want to thank Elizabeth and Nicole. This is just such a lovely example of the development of a tool and adapting a tool in a very rigorous way based on evidence that was gathered right here in BC. So I think it provides such a lovely model that could be used in a lot of other places, but also provides a very useful tool that clinicians and others will be able to use in their practice. So thank you very much for sharing this work today. And I hope by this presentation, you might have a few people contacting you to follow up, either to help you with further research or to find out more about how to use the tool and the training available. So with that, I also want to thank everyone for joining us today. And like Thomas says here, thank you all. I'm very helpful insights. I'm working on a project on the politic of suffering, hence lurking amongst you. So we have all kinds of people interested in this topic. And so I'm hoping you'll hear from some of our participants who joined us today. So thank you once again, all the best in moving this work forward. And it's clear we might have to have you back again at some point to share future developments. So thank you everyone for joining us today and look forward to seeing you all again. Bye for now.